Hi, everyone. We're ready to get started. Welcome to the launch of the National Pediatric Practice Community, or NPPC, on adverse childhood experiences. My name is Lena Singh, and I'm the NPPC Program Manager. On behalf of the Center for Youth Wellness and our project team, thank you so much for joining us today as we launch this exciting new initiative and begin to learn together to integrate an understanding of toxic stress and ACEs screening and intervention into pediatric medicine. I'd like to start by orienting you to Zoom and some of its features to be sure that everybody can see the slides, hear us, and actively participate in today's webinar. If you look at the bottom left side of your screen, there's a Join Audio button, which gives you two options for audio. You can use your computer audio, or you can call in via phone. If you'd like to listen via computer, please choose the Join Audio Conference by Computer option. Some of you might prefer to call in if your internet connection isn't particularly fast, or sometimes because the sound quality is better by phone. If you do choose to call in, dial the number you see under the phone call option. Please note that the participant ID that shows up on your screen in Zoom is unique to you. So if you're calling in, you'll have to enter this personalized ID when you're prompted. That number is not available anywhere else except on your screen in Zoom. If you don't enter this number when you call in, the online system won't recognize you, and then your name won't be associated with any questions you ask or comments you make during the webinar. Some computers will automatically default to computer audio, but you can switch to the phone option. To do so, you have to go into the menu on the bottom left. You choose the Leave Computer Audio and then call in with your unique participant ID number. Please look to the top left or in a pop-up box for the chat function. So this feature enables you to chat with either the panelists or with everyone on the webinar. And during the presentation, we encourage you to dialogue with each other and ask questions via the chat function. Our team will try to respond to as many questions as possible during the webinar, but any that we don't get to now will be addressed in follow-up communications. We will also be asking polling questions of the group throughout the presentation. So let's practice now with chat and polling. Using the chat feature, could you please tell us where your practice is located? We're looking for city and state if you're in the United States, and the country that you're joining us from if you're not in the US. So we can give folks a little bit of time to answer. Wow, it looks like we have people joining from all over the country and the world. This is really exciting. Thank you all so much for participating. Okay, now let's practice with the polling question. You should see a pop-up on your screen in a few seconds that asks what role best describes you, and it provides some options. Please answer via the poll. Great. It looks like we have a really great mix of providers here, a number of pediatricians, some family medicine docs, a good number of registered nurses, and other. Great. Thank you all again for participating. Now that we've practiced with chat and polling, and before we move on, if you're having trouble hearing me, check your audio settings to test the mic and the speaker system. You can also live chat with Zoom if you need to troubleshoot. If all else fails, you can always call into the webinar without your individual participant number, and you can listen in. We are also recording this webinar, and the recording will be posted on the NPPC website. So this is who you'll be hearing from today. As I said, my name is Lena Singh, and I'm the NPPC Program Manager. After me, you'll hear from Dr. Nadine Burke-Harris, a pediatrician and the founder and CEO of the Center for Youth Wellness. Next, we'll have Dr. Susan Briner, also a pediatrician and the medical director for the Center for Youth Wellness. And lastly, you'll hear from Dr. Sarah Marks, who is the Director of Strategic Initiatives at the Center for Youth Wellness. And here are the objectives for today's presentation, to introduce and launch the National Pediatric Practice Community on ACEs. Dr. Burke-Harris will start by providing some background on the science of ACEs and the rationale behind screening. Dr. Briner will then discuss the implications of ACEs screening within the context of clinical practice, discuss lessons learned from the Center for Youth Wellness, and address some opportunities and challenges for screening. Dr. Marks will then address what the NPPC is, what this community offers, who it's for, and how to join. So I just want to thank you all again today for joining us. And with that, I will turn it over to Dr. Nadine Burke-Harris.
Welcome, everyone. I really have to say, I am so excited about this. If there is one thing, I think this is the thing I am most excited about for our entire year. This is amazing, and we're really grateful and excited that you all are interested in participating. To start off, I would like to thank the folks who are making this national practice community possible. The JPB Foundation, the Packard Foundation, Genentech, and Google.org. This is something that we are all incredibly excited about and thrilled to have supporters to make this possible. I'll start by just grounding all of us in the science of ACEs. What is the best of what we know, so that that can be a place where we can build from there. So as we know, the term adverse childhood experiences comes from the study that was done by Vince Felitti at Kaiser and Bob Onda at the CDC, where they asked about 10 categories of adverse childhood experiences. And I'm sure for most of you on this webinar, you're familiar with those as physical, emotional, and sexual abuse, physical and emotional neglect, or growing up in a household where a parent was mentally ill, substance dependent, where there was a parent was incarcerated, where there was parental separation or divorce, or domestic violence. And one of the things that came out of the ACE study was this understanding that ACEs are widely prevalent. In the original study, we know that almost 2/3 of participants had at least one ACE, and 1 in 8 individuals had 4 or more ACEs. In the 33 states that are collecting ACE data as part of their behavioral risk factor surveillance data, we see that between half and 2/3 of adults have experienced at least one ACE, and between 13 to 17% of adults have experienced 4 or more ACEs. But when we look at children, we know from the National Child Health Survey that there are currently 34.8 million children in America who have experienced some form of ACEs. The other thing that we know is that there's a dose-response relationship between adverse childhood experiences and adverse health outcomes later on in life. And we now understand that the mechanism for that, part of the reason that we see this increased risk for health problems, is because of the long-term changes to the brain, the immune system, the hormonal systems, as a result of the repeated, severe, or chronic exposure to adversity. And this is what we're now understanding to be toxic stress. The changes that are associated with toxic stress, we know, affect just about every system in the body. In the brain and neurologic system, we see changes to both the HPA axis, the hypothalamic pituitary adrenal axis, and the SAM axis, the sympathoadrenomedullary axis. I'm so glad I pulled off saying that without stumbling. Right? So we see long-term changes to the activation of our fight or flight system, changes in the activation of the amygdala, which is the brain's fear response, inhibition of the prefrontal cortex, which is responsible for executive functioning, impulse control, toxicity of the hippocampus, which is critical for learning and memory, and changes to the ventral tegmental area of the nucleus accumbens, which is associated with reward center dysregulation and increased risk of engagement in high-risk behaviors later in life. We also see changes to the immune system, which include increased inflammation, and we can see that in inflammatory mediators and markers of inflammation like interleukins, tumor necrosis factor alpha, and interferon gamma, as well as inhibition of anti-inflammatory pathways and impaired cell-mediated acquired immunity. We also see long-term changes to hormonal systems, including ACTH, cortisol, adrenaline, and other hormones. We see inhibition of thyroid function and alterations in pubertal timing. The changes also continue to the cardiovascular system with increased risk of things like increased blood pressure and total peripheral resistance. And ultimately, all of this, a lot of the way that this is mediated in the body is through changes to our epigenetic regulation. So we know that changes to the way that epigenetic markers are placed on our DNA leads to changes in the way our genes are expressed. And these changes in the way our DNA is read and expressed leads to changes in the way our brain and organ systems respond to stress. And finally, we understand that premature telomere erosion can lead to premature cell death and altered cell replication. All of these now have advanced our understanding about how early adversity affects the developing brains and bodies of children. We know that early life adversity is mediated and moderated by both protective factors and also predisposed vulnerability, and that these factors affect the neuroendocrine immune system, which altogether leads to the symptomatology of toxic stress and the clinical implications, which include changes to endocrine, metabolic, reproductive, neurologic, psychiatric, behavioral, immune, inflammatory, and cardiovascular systems. Now, although we know that the ACE study was done originally in adults, advances in the research in the past, in the intervening time since it was published, has helped us to understand that ACEs also lead to changes in health and behavioral outcomes in children. And that piece is really important for us as practitioners. So in infancy, we see growth delay, cognitive delay, and sleep disruption. In childhood, we see asthma, infection, increased risk of learning difficulties and behavior problems. And in adolescence, we see increased risk of obesity, bullying, violence, smoking, teen pregnancy, menstrual changes, among other outcomes. But the good news is that the science also shows us that with early detection, there is a lot that we can do. We know that protective factors make a big difference in how, whether or not adversity leads to a toxic stress physiology. So we understand that one of the important interventions is enhancing protective factors. We also know that with early detection, we can get our patients plugged in to prompt therapeutic intervention. And those therapeutic interventions are myriad. There are a lot of things that we can do clinically to address the impacts of toxic stress. And we also recognize that recognition of adverse childhood experiences is also important in terms of what we do in our clinical treatment. So that's really important. And now I'll talk for a second about screening. So when we think about the fact that ACEs are widely prevalent, they lead to significant health outcomes, we recognize that screening is an important way that we can do early identification for the purposes of intervention. And one of the things that when we review the literature that we see about the benefits of screening in primary care is, number one, that early detection can improve health outcomes. Number two, we've seen in, there aren't a ton of studies out there, but the studies that we look at demonstrate that screening for ACEs can lead to improved healthcare utilization, and specifically those studies looked at decreased ER visits as well as improvements in the utilization of the primary care visit. We see reports of improved patient satisfaction. And we also see that reports that demonstrate that ACE screening is feasible within the context of a busy practice. The other piece that I think is also really important, and what we've been learning about this issue at the Center for Youth Wellness in partnership with the Bayview Child Health Center, is that ACE screening can also improve our clinical decision making. And that's something that we're going to look into more and learn more about as we move forward in the practice community. But as we're talking about the concept of screening, the question is, how the heck do we do this in our busy clinical practices? And to share more about that, I will pass the baton to my colleague, Dr. Susan Briner, our medical director.
Thank you, Nadine, and welcome everyone on this webinar. I am going to tell you about a place where screening for ACEs in the pediatric medical home has been routine for several years already. I'm going to provide you with a high-level overview of our screening protocols now. How did we make screening a reality in clinics? At the Bayview Child Health Center, we screen using a tool called the ACE-Q for ACE questionnaire, which was developed by Nadine and the CYW research team in 2015. This screening tool is divided into two sections. The first section asks about the exact same 10 traumatic events addressed in the original ACEs study by Drs. Anda and Felitti, those that are grouped into the three categories: abuse, neglect, and household dysfunction. The second section asks about exposure to additional early life stressors, which were identified by local community stakeholders. Those are stressors such as involvement in the foster care system, loss of a parent or guardian due to death or deportation, exposure to community violence. The ACE questionnaire is available in 3 age-specific versions in English and Spanish, and it takes most individuals less than 5 minutes to complete. Parents are asked to complete an age-appropriate questionnaire for all ages, and we also ask adolescents ages 13 to 19 to complete a self-report tool. Respondents are asked to report how many experience types or categories apply to them or their child, not which specific experiences they have had. We call this de-identified screening because it permits us to calculate each child's health risk from cumulative exposure to ACEs without asking that specific experiences be disclosed or identified. Pediatricians review the results of the ACE screening tools before entering the exam room because our approach to history taking and physical exam for that patient is informed by knowing his or her combined ACE score in advance. For kids whose reported ACE score is 1 or more, we conduct a review of systems which focuses on symptoms known to be indicative of toxic stress. For example, sleep disturbance, school problems, encopresis, anxiety, high-risk adolescent behaviors. Patients who have an ACE score of 1 to 3 with relevant symptoms are offered a referral to the Center for Youth Wellness. All kids with an ACE score of 4 or more, whether they are symptomatic or not, are encouraged to seek care at the Center for Youth Wellness, where care coordination, psychiatry, and psychotherapy services are available. All patients whom we screen for ACEs receive anticipatory guidance on how to manage stress. By the way, all of those details that I just shared with you are available in what's called the ACE-Q User Guide online at the Center for Youth Wellness.org. Almost everyone listening to this webinar can recognize that screening for ACEs will require not small changes in practice, but significant ones. Almost all of us know that change is hard anytime, even when it's the right thing to do, and that sustaining change is even harder. Adding screening for ACEs to any practice setting will require changes in workflow from the front desk to the exam room, and we know that staff and patients alike may respond to screening with deep emotions. In other words, there are quite a few barriers to screening, and we can acknowledge most of them ourselves today. Probably number one, lack of time. As pediatric providers, we're already trying to squeeze a lot into each visit. Doing everything recommended by Bright Futures and or the periodicity chart is already daunting. There's a lack of provider comfort and perceived negative patient reaction. Why, patients thought they were just coming in for a routine checkup, and now we're asking them whether they've ever hurt their child? A weak or non-existent referral system may be a big barrier for some people. What exactly am I going to do if I find out that this family is in need of immediate support and the waiting list for mental health services in my community is at least three months long? There is a fear of providing incorrect information. If a child has been exposed to ACEs, what does that really mean? What can I share with the family? What's the good news? What are the options for responding? To be frank, one of the biggest challenges to ACEs screening we've found is a fear of clinic liability and increases in cases of mandated reporting. We won't go into that in great detail right now, but we at the Center for Youth Wellness have a strong sense of confidence around our de-identified approach to screening for ACEs, which we can share with you later. Finally, there are questions about tools and scientific foundation, things that we're trying to address today. And also, there is a perception among some that the issue of adverse childhood experiences is limited to certain populations, whereas we know that it applies to all. With these barriers in mind, based upon our experience at the Bayview Child Health Center, I would like to offer 3 key recommendations which will help overcome the majority of these barriers to the introduction of ACE screening in any pediatric setting. The first thing I'd like to suggest is that you diligently incorporate known best practices of quality improvement when undertaking any practice change, and certainly this one. Set goals which are specific, measurable, and feasible. Design the change process with input from all members of the practice team. Start small with simple plan, do, check, act cycles rather than waiting until you think you have it all figured out. Learn from what does and doesn't work well. Secondly, I urge you to contextualize the concepts of adverse childhood experiences for each member of your staff before you actively start screening patients. share information about toxic stress in scientifically accurate layman's terms, and promote wellness and stress management for everyone in your practice. Write sample scripts for medical assistants, nurses, and providers to assist them in speaking with families about ACEs. The third is also very important, and that is normalize screening for ACEs among your patients. Make clear that everyone is being screened for ACEs, just as everyone is asked about his or her past medical history, his dietary habits, whether he's allergic to anything. At the Bayview Child Health Center, for example, we post signs in the lobby and exam rooms that say, "We screen everyone," and introduce the concept of ACE screening. This next slide may look familiar to those of you who are familiar with motivational interviewing and the stages of change model. We assume that most of you who are participating in this webinar have already passed through the pre-contemplation stage and are actually contemplating a change. That is, you're considering screening for ACEs in your practice. And our discussion so far has been structured to help you take genuine, determined action in that regard and then maintain that change. So please tell us, how would you describe your readiness around screening for ACEs in your practice? So what we're seeing is a pretty even split around those who are already actively screening for at least one ACE, and a combination of those who have some support but no concrete plan. And then there's about 20% of you who are still exploring. And we're glad to have all of you in all these stages on this call today, because the reason, what brought us all together today, is this: the importance of early detection and intervention coupled with barriers has led us at the Center for Youth Wellness to develop a pediatric community of practice built around ACEs and toxic stress. I'm now going to hand you over to Dr. Sarah Marks, Program Director for that National Pediatric Practice Community, to get more details about our plans for this community.
Hi, everyone. We are super excited. Thank you, Dr. Burke-Harris and Dr. Briner, for giving that introduction and really laying out why we came here together. We've heard some of the science on ACEs and toxic stress and the important reasons around what makes early detection of ACEs in clinical practice important and challenging. Our goal with the National Pediatric Practice Community is to advance dialogue, raise questions, and push forward the fields of research and medicine, allowing research to emerge from our practice and to inform our practice with the research, and to create a network that shares resources and support around the implementation practices. So our ultimate vision is that all primary care pediatricians and other primary care pediatric serving clinicians screen all children for adverse childhood experiences and use that information to enhance the quality of patient care and health outcomes. To do that, we know that we have a lot of questions that need to be answered, and there's a lot of information that exists out there that we need to bring together so we can learn from each other. So the National Pediatric Practice Community on ACEs is a virtual community of pediatric medical providers who are leaders in advancing this practice around ACEs and toxic stress. The community has a co-designed approach that ensures that the materials and training are responsive to member needs. As you can see from some of the polling questions that we've already put out there, we're taking that information and we're creating materials, finding materials, that will respond to where the community is and what their needs are. It has a national reach, which we hope will allow for many different experiences and perspectives to feed into our dialogue, as well as to help us establish geographic hubs of support, because we realize there's a lot of contextual differences in how this plays out in practice. We're building off a clinical learning community model, which has been found to be effective as clinical practices consider and adopt new innovations. We know that while some of that work is very practice specific and you just have to figure out how it works for you, there's a lot of learning that can be shared between practices. And so we're going to try and do that in a virtual manner, largely virtual with some opportunities for in-person work as well. So who is this practice community for? Though there are many child and family serving professions that are critical to allow us as a broader community to address ACEs, the NPPC is really designed to work with folks involved in this topic from a medical perspective. So we're looking to work with pediatric-focused primary care medical providers and their teams. We're looking to involve medical practices that are at any stage of implementation of ACEs screening and intervention. So that means folks who have been thinking about this for a long time and trying to make it work in their practice, and folks who are brand new and still exploring the topic to see if it's the right fit. We know that the field is still pretty new, and so all of us have a lot to learn, and we can learn from each other. So what does the National Pediatric Practice Community offer? The community will give members an opportunity to expand knowledge, build capacity, learn collaboratively, and shape the field. The community plans to do this through a variety of ways, including hearing from experts in the field and practitioners who have experience in ACEs screening, virtual coaching and trainings focused on addressing barriers to screening, many of those that we've already talked about today, tools and resources for practice, including patient educational resources, sharing the latest scientific information that's emerging on the topic of ACEs and toxic stress and its medical implications, and offering an opportunity to get involved in further learning. So we're hoping to find opportunities and share them through this network that allow us to do sub-studies and to learn about how we can integrate innovations into practice around ACEs and toxic stress. NPPC members will receive monthly updates and will be offered the opportunity to participate in webinar communications. The information will be shared. The information shared will be largely drawn from the identified interests and needs of the community, as I mentioned. And regardless of where you are in your knowledge and practice, we will be developing and sharing materials that help advance that practice. So let's put up another polling question. So of the things that that we've mentioned, and a list will be popping up in a second, which of these would you be most interested in? All right, looks like we've got interest across the board. If there are additional things that are not popping up here for you that you would love to see as part of this practice community, please send them by chat. All of this information is useful for us, again, to ensure the co-designed nature of the network. So one important part of the practice community, in order to really allow us to learn collaboratively, requires some data collection. and some participation and feedback requests. And so what we ask of members is that they participate in this process, and that includes at sign up, there is an assessment and some basic information, demographic information that we'll ask for. And then over the course of participation, some additional moments in which we'll be reaching out to gather feedback, both on the materials that are put out there to see if they're actually applicable to your practice and to your needs, if they're written in a language that is useful and appropriate for you and your community, as well as learning about your process as you're implementing and advancing your screening work. I also want to take a moment to talk about a subgroup of folks who will be members of the National Pediatric Practice Community. These are pilot sites. And for this year, this subgroup will be receiving tailored clinical quality improvement coaching focused on the implementation of ACEs screening. And with this group, we'll be achieving a greater or deeper level of learning about clinical transformation and the adoption of ACEs screening, which will provide critical insights to the larger group. For 2017, this cohort is really going to focus on working with individuals who have no screening protocol in place, but are highly interested in doing so. Let me tell. Just a quick note here, we are still recruiting for pilot sites in California. We're looking for 4 pilot sites in California. And so if you're interested, please let us know, and we'll be giving you more information about how to contact us at the end of the webinar. So we've reached the point where we're going to tell you how to join, and we hope all of this sounded really interesting to you. This community can only come together with your participation. The materials that you'll help contribute and share with the field are going to be invaluable as ACEs screening gets shared more widely. So to join, we ask that you be a pediatric-focused primary care medical provider or member of that team, that you're interested in integrating ACEs screening into your practice workflow, or if you already have this practice in place, that you're looking to advance that practice, improve that practice, be ready to adopt new innovations as the science comes out. That you have a willingness to respond to basic data collection requests, and that you have a capacity to use web-based meeting services, which I hope you can cross off since you're all online anyway now. So to join, immediately following this webinar, you will be receiving an email that has information on how to sign up. You can also go now to nppcaces.org, go to the join page, and complete the registration information. What you'll find there is a short baseline questionnaire and participant agreement. Once you complete that and sign up, you'll receive confirmation. And in the coming months, a member login page or a member-specific page will go live with information that responds to what we've learned so far from our members. For more information about the enrollment and membership, please contact Lena, and she can provide any additional information that you might need. Thank you. We have a few moments for questions, and so we're going to respond to those. We have a question here about pilot sites outside of California. So for right now, our funding is only allowing us to have some pilot sites in California as well as in New York. And we have our New York sites on board already. We are very hopeful that we will get additional funding, or that folks who have funding for themselves will want to reach out and work with us more closely so we can support you in, through our coaching in your implementation process. We have another question here around, could you join if you are a developmental and behavioral pediatrician with a consultant practice? So while we're focused on communicating these materials from a medical perspective, we believe that this work is best done in integrated behavioral health, with integrated behavioral health. However, that's not everybody's reality. So if you work within a team and you come with your medical practitioner and you are the behaviorist, everyone's willing to join.
Yes, but this is Nadine. I'm jumping in. If you're a developmental pediatrician, our focus is screening in primary care, so that which is where early detection really takes place. Chances are that by the time someone has been referred to you as a developmental pediatrician, that being said, we won't kick you out. You can join if you want to. Yeah. I think that's fantastic. Particularly if you are part within your system or your setting of working with others who are doing a screening, that would be fantastic. So we welcome you, developmental and behavioral pediatricians.
We're getting some questions on where information on evidence-based interventions are housed, as well as other resources. To our knowledge, there is no current clearinghouse specific to ACE's interventions based on score. In part, what we'll be doing through the NPPC is sharing information around interventions. There are evidence-based interventions and clearinghouses for those in the behavioral health field. But again, that's part of what we're trying to build.
And I'll just jump in here that our research team here at CYW has spent the last 2 years reviewing 15,000 research articles on the impact of early adversity and health. And part of what we'll be doing through this national practice community is understanding what areas are of greatest interest to members of the practice community, and then working with our research team to be able to provide that information and that science to you in a way that's most useful.
Yes. A question here on the time frame of the commitment. So the National Pediatric Practice Community initially is conceptualized as a 3-year project, and then we'll see where it goes. It is your participation can be as involved as you want it to be, though we do hope that you will become an active member that can help grow everybody's knowledge base. So we'll probably be checking in 1-year intervals to collect information and make sure that the community is still responsive to the needs of the group. We also have a question here from somebody who is outside of the United States, listening in from London. And in secondary, is there a precedent for screening of ACEs in secondary care setting? Nadine, would you like to talk about that?
Yeah, I'm happy. It's happening. There are more folks in the hospital setting who are screening for ACEs as part of their care. And what we're seeing in the research is that they're finding that ACE scores may impact, for example, efficacy of pain management, that it may impact other parts of hospital-based care. In terms of the suitability for someone in a hospital setting to be part of this national practice community, I think that most of the tools that we will be working together to share and to evaluate are really going to be focused on the primary care setting. So I'm not sure if it will be as useful for folks in a hospital setting, but we certainly, I think the aspects of it that may be more useful are things, tools around how we're screening, right? How we're screening, whether it's in primary care or inpatient, may certainly, there may certainly be learnings that you might be able to take away from that. So I would say it's up to you, but know that the direction of this group is primarily outpatient.
Great. And another question here on involvement in the program. So Does the involvement in the program involve a data registry, and does it require practices to provide patient data? No identified patient data will be requested. We may, at some point, if you are screening, ask you for approximately how many patients you are screening and at what intervals, to more along your protocol, to try and learn from that, but nothing individual and nothing too complex that would be have you pulling specific information. There may be opportunities at some point down the line to participate in sub-studies that would be more data intensive, but those would be, you know, RFP processes for folks who are interested in doing that kind of research. There's a question here: should ACEs screening be part of preconception and pregnancy care?
That's a great question. This is Nadine. My answer to that is certainly. I think that, let me rephrase that. The data would suggest that it should. We know that individuals who have high ACE scores are more likely to exhibit teen pregnancy and teen paternity. In the original ACE study that was done in Kaiser San Diego, it was over 40%. I think it was around 45% of young women, of the women in the study who had an ACE score of 4 or more, had a teen pregnancy. And so with that prevalence, it would highly suggest that ACE screening and counseling about the impact of ACEs on impulse control and pleasure and reward seeking and other things like that would be an important part of contraceptive care.
Thank you. Susan, perhaps for you, we have a question here that says, do you have any information on how patients and families may feel re-traumatized by the ACEs questionnaire, or negative responses expressing that the questions are overly invasive?
That is one of the barriers that a lot of people bring up, and one of the fears that a lot of people have. I can share my own experience, and I can also share the experience of one of our partners. It's research partners that's doing a much busier practice. And overwhelmingly, I can say that families are thankful that the conversation was started. Instead of perceiving of it as intrusive, they often are relieved that we asked. That doesn't mean that it doesn't involve a strong emotional reaction and call forth strong feelings about things that have happened. And if you're a provider who begins to screen for ACEs, or you're currently screening for ACEs, you will recognize the importance of recognizing that in yourself as well when you work with families. But the overall preponderance, based upon my experience and Nadine's as well, is that people are actually relieved to be asked rather than offended.
Yeah, as I travel around the country and I talk to other providers who are either screening for ACEs or considering screening for ACEs, I hear the same thing in terms of the fear of opening Pandora's box, and the fear that patients will respond negatively. But overwhelmingly, from the clinicians who are actually screening, most of their patients express either a neutral or more often a positive response. Now, does that mean that there will never be a negative response to ACE screening? Certainly not. And I think that's something that we learn as part of our clinical skill set is how to manage those when they come up.
And if you go back to my original suggestions, that you plan it carefully, that you design the process in a way that leaves room and privacy and occurs at a time when people are not too tired out from having been in the doctor's office so long already, that in a methodical and respectful time frame, with contextualizing the reason I'm asking and how this matters, it isn't very hard to do.
Thank you. I'm seeing a few questions pop up here that have to do with time commitment, being a pilot site, those types of questions that are about the National Pediatric Practice Community. And I just want to be sure that that I was clear in the description. So there are sort of two levels of involvement in this practice community. There is a broad level that is primarily a virtual engagement that would include receiving information regarding ACEs, the scientific information, being made aware of training opportunities and speaking opportunities related to learning about ACEs and ACEs screening, and then participating in some high-level feedback so that we ensure that those materials are responsive to your needs. The amount of time that's required to participate in that is largely dependent on how engaged you want to be. So for practices that are really trying to advance their and develop their own screening protocols, a lot of work on your end would have to be done within your own practice. And we hope that these materials would be supporting you as you do that. For those who are still exploring the topic, you may not be actively doing very much in your practice quite yet, and hopefully we'll be moving towards that as you engage in the materials. That is for everybody on the call. Anyone can join that. Again, the materials are largely focused on medical providers and will be written for clinic operations needs. Within that group, there's a subgroup that will be pilot sites. And those groups, those sites specifically are ones that have yet to do any screening. They don't have a protocol in place yet, but they're highly interested in doing so. Those are the folks who, the sites that we're looking for in New York and California, and hopefully we'll be able to expand that beyond those two locations in the near future. If you are someone who is interested in becoming a pilot site, which would involve accessing some of our more tailored coaching opportunity, please email us and let us know where you are and what your clinic looks like, and we can talk about that and look at how we might fund that opportunity. I hope that helps clarify. And let's see, I think we probably have time for one or two more questions. So for practices and organizations who are not in California or New York, what are their next steps after the webinar? Again, if you're interested in being part of the National Pediatric Practice Community, the broader reaching, we're hoping sort of everyone interested in this topic area from a medical perspective can become enrolled and involved so we can have an engaging dialogue. You go to the nppcaces.org website, click on join. There's an assessment there. You fill that in and you will be a member, and you'll be hearing from us shortly after as content starts rolling out. Do you recommend the use of ACEs screening and evidence-based home visiting programs in addition to using in a pediatrician's office or in lieu of? There was a similar question around the use of screening in school-based health centers. Do either of you, Nadine or Susan, want to talk about the use outside of primary care?
You know, I want to say I'm so impressed by all the great ideas that we hear of all the different kind of sectors where screening for ACEs can be important and help inform the way that providers who work with children and their families can approach them in a more meaningful way. What we have decided at the Center for Youth Wellness is our expertise is primary care pediatrics. And so though we would like to branch out into many different areas, we're going to try to stay focused on that goal, helping to launch the screening for ACEs in primary care pediatric settings all across the United States and beyond. And keep ourselves focused on that goal, because we believe the pediatric practice is a center for the lives of kids, and that if we can get it right there, then it will spread into some of those other areas. So please share all your ideas for the places that it might be active, and we'll send back some resources for you where you can get in contact with other groups that are thinking like you.
And I want to emphasize again what the point that Dr. Marks made, which is that this is a co-designed network. So while we have some foundational ideas about what we think is important, what I'm most excited about is hearing from all of you in terms of what you think is important, what you care about, the different applications that you see for ACE screening, how you're using it, what challenges you're encountering. And our goal is to be able to problem solve these things together. So we look for this to be truly a co-designed process, and it seems like it's shaping up to be that already.
Yeah. And on that note, I just remind everybody that this webinar will be posted online on the website shortly. So please send anybody who you think might be interested in this but was unable to join us today information about the practice community. We want to get as many people involved as possible so that we can really have an engaging conversation that supports moving, expanding this practice across the country and world. Thank you.